For those of you that never had the privilege of and pleasure of meeting me, joke, I am Lori Clark, Legislative Counsel to End Jobs. And I have the honor and privilege this morning to introduce someone who has done so much for our state. He's a hard worker, he's industrious, and it's really kind of thankless, his job, but thanks to him, we're here. And I'm not so sure we would have been here if it wasn't for him. Dr. Adinaro is an emergency physician who was appointed the Deputy Commissioner for Public Health Services in the New Jersey Department of Health in June of 2020. So you get the timeline. As the designated state health officer for New Jersey, he oversees 4 divisions: epidemiology, environmental and occupational health, family health services, which includes HIV, STD, and TB services, public health infrastructure, laboratories, and emergency preparedness. In addition, 3 offices: local public health, opioid response and policy, and women's health. Public health service is the largest branch in the department with over 900 employees. Dr. Adinaro has been integral to the pandemic response, including policy, epidemiology, medical countermeasures, strategic stockpiling, testing, contact tracing, and isolation quarantine. As the chair of the state's COVID-19 vaccine task force, he leads the unprecedented efforts to immunize all who live, work, and are educated in New Jersey. These efforts have required close coordination with response partners, including NJOPS, in and out of state and federal government, and have resulted in over 16 million doses being administered to date. Dr. Adinaro joined the state's initial response as the Chief Medical Officer of the Field Medical Station North, a 250-bed field hospital set up in a convention center to relieve pressure on the overwhelmed hospitals. Prior to joining the Department of Health, Dr. Adinaro spent 17 years as an ER doc and leader at St. Joseph's Health based in Patterson. Please help me welcome this phenomenal public servant and physician.
Thank you. Good morning. I think we're still in morning. And you can hear me okay? I'm not known for being quiet, so I figured that would work out all right. You know, it's interesting. As I'm going to go through these slides, and I do want to leave some time at the end for questions. I completed these about 2 weeks ago, you know, get them in for approval and everything else. And what I realize is how much has incrementally changed in those 2 weeks. And I'll try, as we're going through the slides, to try to update where we are, some of the things that have been happening. And part of that introduction is a little bit old. Right now, I think we're at almost 18 million doses administered of vaccine to people who either live, work, or are being educated in New Jersey, whether in the state of New Jersey or at some of our neighboring states. So, you know, things continue to change in this pandemic. Some of the stuff, I mean, everything I'm talking about really, I think, is related to the policy of the Department of Health, but for the purpose of the disclaimer, anything that, when I reflect anything that's particularly my opinion, I'll point that out. I appreciate that introduction. I like to joke, there's 2 things that hospitals never trust physicians with: budgets and personnel. And pretty much the Commissioner of Health has given me nothing but budgets and personnel. So it's been an interesting couple of years to adjust into. Like most Department of Healths, whether it's our local health departments or on a state level, New Jersey has not been well funded, just in terms of where the national dollars have been available, what's happened in the last 20 years, particularly since a lot of the funding that came in around September 11th and things like anthrax, et cetera, and how much particularly the federal funding had dried up, which meant that, you know, things had moved forward. And, you know, it's interesting, we were going through and getting ready for budget prep and really total up the money. And we've had, just from the Department of Health point of view, about $2.3 billion, which is basically the equivalent of 1 year budget for us, a little over 1 year's budget, has been made available by essentially CDC, FEMA, et cetera, just for some of the things that we're doing in the pandemic. So it just shows you sort of the scale of what's been needed versus, I think, what we've had as we've moved forward. So my goal is really to talk about where we are right now, which is always dynamic and is as a point in time. So as I said, some of the slides that are from a week and a half, 2 weeks ago, things are a little bit different, and I'll point that out. talk about what some of that statewide responses look like, really bringing up to today, which would include some talking about some of the therapeutics and some of the ongoing efforts we're doing on trying to get the word out around the therapeutic side, some of the preparation we're doing for the future, and really our future is, as we move into whatever this new phase is of the pandemic, whether you want to call it the endemic state or just recognizing that COVID's going to be with us for a long time, and we're going to have to bake in our approach and response into that and expect surges, et cetera. Really some of the things that we're talking about on a state level to really move through the next couple of years and also try to get to the Department of Health back to addressing all the things that it was working on before. I think one of the things that's very apparent, maybe with the exception of last year in the flu, the rest of the diseases of humankind have not recognized the supremacy of COVID. We have, increasing number of sexually transmitted infections. We have, we're worried about our HIV numbers. We're still having overdoses. We've, still working on TB. There's still a lot of things going on in the state of New Jersey that we need to be able to do at the same time we are trying to address the pandemic. There's about 4 different things that can tell you where the state is at any given time. We use the Cali score. A lot of our regulations are tied to this. A lot of the executive orders and executive directives are tied to the Cali score. Obviously, the federal government has its own things, but we've used this fairly consistently. And as you can see, all of New Jersey right now has been in yellow. This has been for the last 2 weeks. One of the calls I was on this morning was at the epidemiology team giving the commissioner their weekly update. And there is a possibility of some of our counties, if the numbers continue in the next week or two, moving into that high category. Particularly for this one, based really on number of cases and the percent positivity. And as you can see, while this is a couple weeks old and has changed a little bit, we're significantly, in terms of the resources that we're most concerned about, which is really our hospitals, ICUs, ventilators, the things that we've had issues with in the past. We're sitting, it was 370 admissions for people who were either positive or suspected to be positive for COVID, though interestingly enough, most of them, at least in terms of the identification by the hospitals, were not being admitted specifically for a COVID-related condition. That number is probably closer to about 460, 470, so it's moved up, a fair amount in the last 2 weeks. Interestingly enough, ICU and ventilator patients that are requiring ventilation that are COVID positive haven't moved as much. And again, we've been fortunate that the number of deaths being reported every day have remained around single digits, so in that 5 to 15 deaths related to COVID per day category, and we haven't yet seen a bump. Though we know that's one of the later indicators that we're seeing, but we are concerned that hospitalizations are beginning to move up. Again, are we likely right now in our modeling to see what we saw, in the beginning of the pandemic or even in December or January of our most recent surge? Probably not, but we are keeping a close eye on this. We've traditionally, for COVID, this is our third kind of spring, New Jersey has seen a large number of cases in April of 2020 and also April of 2021. And we seem to be a little bit on sort of a early spring, middle of winter, or seem to be the 2 peaks we see, where some other states, let's say Florida as an example, has tended in these couple of years to see more of a summertime peak. So we keep an eye on this closely. The hospitals continue to report this. But at least the indications are that we're probably going to see a continuing increase in cases. And in this, you can see that on the upper left-hand corner, we're at this point 2 weeks ago, averaging about 1,800 positive PCR cases reported into the state. Today's was about 2,600. We also recognize, obviously, that we are not capturing every test. We're capturing every PCR. We're capturing probably every rapid antigen that's being done in a larger setting that is required to report to us. Certainly home testing we're not capturing. And the data last week that the CDC put out, which we've seen indications of suggesting that upwards of 60% of of Americans have had COVID, and that roughly probably about half of that occurred from November to about February, particularly if you're looking at children and some younger adults. So we know that we're not capturing it perfectly. We still think our numbers are valid in terms of looking at a day-to-day comparison. They may not be as useful in terms of a quarter-to-quarter or a year-to-year comparison, though. And again, I think one of the reminders of where we went through, as you can see in the very beginning, there were not a lot of cases. That doesn't mean that there weren't a lot of people who had COVID in the very beginning. In March and April of 2020, just meant our testing capacity was very limited, the ability of people to be tested. And as you can see here, it looks like both the United States and New Jersey were on that downswing and kind of leveling off. If I was to do this for today, you would see a steeper increase for New Jersey in terms of number of cases than you're necessarily seeing for the United States, but both are increasing. And of course, for deaths, New Jersey had been for a long time in terms of deaths per capita, so per 100,000 residents, we were number one, unfortunately, for a long time. As quite frankly, the success and particularly of our citizens being willing to get a vaccine and then get a second vaccine and then quite frankly coming in and getting a booster and maybe even considering a second booster, we've now moved to I think 8th in terms of overall death. And from a trajectory point of view, it is likely that we'll continue to move down as more and more states move. If you take out the first couple of months, and particularly hardest hit nursing home residents in particular, New Jersey has done fairly well in the other surges when it comes to both hospitalizations and death. In comparison, though obviously I think in this Omicron era, cases still remain very high, and particularly in the Northeast and New Jersey and New York in particular. Variance is another thing that has changed in the last couple of weeks on this slide, which is everything was reported about 2 weeks behind. So this is through the week of first week in April, so April 2nd. As you can see from this, we're basically 100% Omicron with about 85, almost 90% of that as the BA2 variant. If you were to look at the one from this week, so that's been 2 weeks further on, what you will see is that there is almost no BA1 in the state of New Jersey. BA2 makes the majority of it, and the BA2.121 variant, so that's sub-variant, is making up about 15% of what's reported, and based upon the Region 2 predictive data, probably makes up closer to 70% of what actually is occurring right now in New Jersey. What the significance of that is, I think, is unknown, whether or not these subvariants are any different than Omicron. Clearly, Omicron has had a larger footprint in terms of transmissibility than Delta had previously. But it's a little bit unclear what the significance of BA2 versus the BA2 subvariants will have in terms of morbidity or mortality. But it's very clear that with probably the next couple of weeks, this BA2.121 subvariant will probably make up almost 100% of what's in New Jersey. As of right now, there are no other variants of concern that seem to be making any footprint in New Jersey. Again, I did lectures in the middle of August of 2021 where I said that about Delta, and nobody else was making any thing, and Omicron came along. So by no stretch of the imagination do we think that we're at the final variant. And quite frankly, I think one of the most interesting things is how much sequencing we've had and how much the genomics of this virus really has been documented, and in what that may mean in terms of some of our decision making. This is one of my favorite slides because I think this is what's consumed a large portion of my life over the last year and a half. It has only been roughly 16 months since the first shot was given to an ER nurse at University Hospital on, I think it was December 16th, I believe. And as you can see, even 1 year ago, we were at about 7.5 million doses given, and we're going to break probably about 18 million doses in the state with probably by the end of May. So when we initially set a goal of 70% of, at that point it was adults because that's all we had, that we wanted them, we wanted 70% of adults to get at least one dose of a vaccine within the first 6 months. People thought that was pretty aggressive. And as you'll see, I think through a lot of work, and I think the communication and that has happened, and particularly the importance of physicians in that conversation and encouraging their patients and family members to consider the vaccine, has really gotten us to where we are now. So it's kind of a busy slide. I think the green highlighted areas are the important thing. This is as of about a week ago. We're estimating that about 92% of those that are over the age of 5 in New Jersey have received at least one dose of a vaccine. That almost 80%, so 78.85% of those that, again, are over 5 have completed their primary series. And then about 54% of those that are eligible for a booster, and keep in mind the 5 to 11-year-olds currently are not in that category, about 54% have come in and received a booster. And because we now have a number of people, and we're using the potentially eligible population here as we're really focusing on those over 50 who've had a first booster greater than 4 months ago as the denominator in this. We're at about 15%. I think we have about 230,000 individuals who we've identified that have come in and received essentially a 4th dose of an mRNA vaccine. And just to show, I think, and then we'll talk a little bit about some conversations. Moderna today asked for authorization of their emergency use authorization for under 6 for them. And it's interesting, they've had requests for the younger populations under 18 probably for almost a year now, but they've submitted data specifically for the under 6. Pfizer, I believe, is doing the same thing or will do it shortly. There's some indication that we may be seeing some form of an authorization for the under 5. End of May, beginning of June seems to be sort of the unofficial conversations we're having through the federal government, from our federal government partners. But as you can see, age does make a difference. So, we're currently saying that we believe that close to 100% of those who are over the age of 50 in New Jersey, and again, it's always hard. We use census data from one generation. Obviously people age during the time period we've been delivering the vaccines, et cetera, but close to 100% of those who are over the age of 50 in New Jersey have received at least one dose of a vaccine, majority of them completing a primary series. And for the groups that we're very much worried about, which is the over 65, we're estimating about 70% have also then completed a booster. But you can see on the opposite side that if you're looking at the 5 to 11-year-olds, we're well below 50%. We're a little bit off in terms of nationally, we're a little bit be above the national average. If you look at the Northeast, which is where we generally compare ourselves to, Massachusetts is closer to 50, 55%. So we're a little bit lower than some of the states that we tend to benchmark ourselves against. Though overall, if you look at our overall vaccination rate for COVID, we're somewhere around the top 6 or 7 states in the country. But also, interestingly enough, lag a little bit in terms of the booster doses, even for our older population. You can see this drop off from the 18 and 29-year-olds down to the 5 to 11. So it is sort of an open question on what the under 5 would look like moving through it. And obviously one of the things that changes, and we try to address this as much as we could, particularly for the 5 to 11 category, there will be some significant logistical issues as really the pharmacies are not going to be able to deliver vaccines to the youngest parts of that cohort that may come in. Race, ethnicity data, gender. We had a gender gap. If you're looking on the far left, this is for primary series. This is for all booster. As you can see, what started out as about a 5% gap between male-female in the primary series has now become about a 10% gap in terms of when people identify their gender. Males being less likely to have gotten a booster. Concerning because, I think some of the evidence does show that in terms of some of the groups that we're concerned about, certainly males fit into some of those risk categories. And unfortunately, the same thing is we're seeing in terms of communities of color. We were very fortunate that in our primary series that roughly about 20% of our sorry, take that back. That percentage-wise, about 25, 26% of the vaccine recipients identify themselves as being from a community of color in the primary series, these two here. But if you're looking at our, for boosters, that number actually moves down significantly to about 17%. The largest loss is in those who identify as Hispanic or Latino. So it kind of talks about some of the challenges that we're having and where we're focusing a lot of our messaging efforts in looking at who's been coming in, who's been getting these the vaccines. The availability of vaccines remain pretty robust. We estimate there's about 1,900 locations that have inventory of vaccines, that probably 1,200 locations in the state have delivered a dose in the last week, week and a half. So that gives us a fairly strong availability. We've broken this down in terms of some geospatial analysis. We estimate that there's about 200,000 New Jerseyans out of roughly the 9 million residents of New Jersey who are not within either a 15-minute walk or a 30-minute drive of a place to receive a vaccine. That number had been as high as 1 million during certain parts of our campaign, so we've been really worked hard to try to identify as many avenues as possible to get the vaccines out. And this data is only based on boosters, so because that's the majority of the vaccines that have been delivered in the last 6 months. And as you can see, somewhere around 70–75% of the vaccine is being administered in a pharmacy. Though I have to say that the medical practice part of this, while it does not look very large, has actually increased on the booster side in the last 6 months in comparison to what we saw before. Part of it is it's hard to make a comparison to the very beginning because obviously the mega sites and county-based sites and FEMA coming in, I think changes it a little bit. And again, if we were looking at pediatric vaccinations, so particularly those under 11, medical makes up a much larger part of that part of it. But I just wanted to give an idea of where the booster vaccines in particular, where vaccines are being delivered over the last few months. So then and now, I think, unless you've been living under a rock, you are probably familiar with all of these key events. March of 2020, the state of New Jersey declared its first public health emergency ever. The peak was April 14th of 2020, where 8,300 people were hospitalized with COVID. That was a high watermark, and fortunately has been the high watermark throughout the pandemic. I won't tell, and most of you have lived through this. That was my first experience of the Department of Health. I was, in February, I was taking some well-deserved time off, having transitioned from one job and trying to figure out what my next job was going to be. And the pandemic started, and I thought I was going to be the only emergency physician who was going to be sitting at home. And I got a phone call from somebody who was, at that time, a deputy commissioner in the Department of Health, who knew I was at home and said, hey, do you want to be a chief medical officer of this field hospital? We're going to, have at that point, we thought there were going to be a lot of non-COVID patients that we could decant out of hospitals. So I said, sure. I started on March 31st. By April 8th, we opened up with the first patient. And of course, there were no non-COVID patients in the hospital by then. So we started taking essentially COVID recovering patients, so people still required oxygen, physical therapy, into essentially what is a convention center in Secaucus, with a staff that was some National Guard, and quite frankly, a lot of people who volunteered, and they were paid, but essentially most of our nurses were school nurses who were at that point unemployed and at home, and a lot of our physicians, quite frankly, were surgeons who did outpatient medicine because everybody else was sort of busy doing everything, and these people volunteered. So it was a very interesting experience, and fortunately we have not had to replicate that, as I think We've figured out who should be hospitalized, how we can keep people at home, and quite frankly, hospitals found ways to expand their capacity. Again, first vaccine starts on December 15th. We hit 1 million doses on February 11th. We have another surge in April of 2021, where we have only about 2,400 hospitalizations at its peak. And then getting into more recent history, on January 11th of this year was the most recent peak with almost 6,100 patients hospitalized. This was a number that I think, while it stressed our systems incredibly, it was something that the hospitals were able to handle. We had some disruption of services as elective surgeries, et cetera, were canceled, but not, I think, to the level of what we experienced on either of the two previous surges. And again, we still operate while the public health emergency is lifted. The state of emergency remains in place, which gives us the ability to do many of the things that we're currently doing and require some of the reporting that we're requiring also right now. When I came into this, the pandemic modeling, so in June of 2020, when I joined as the Deputy Commissioner for Public Health Services, a position that by law or in statute has to be a physician if the Commissioner of Health is not a physician. And my boss is a nurse by training, so either the Commissioner of Health or the Deputy Commissioner for Public Health Services has to be a physician. The position had actually been empty for about 14 months when I had come into the position. And it's always interesting coming into something that's been empty for a while and also in the middle of a pandemic. This part is what they had worked on a lot: the modeling, surveillance, testing, a lot of the collaboration, getting more data out to the public, getting our dashboards up, et cetera. PPE supply and planning was a topic. At that point in June, I think we had stabilized in terms of demand for ventilators and beds, et cetera. ICU capacity and planning, we had shut down by June. The field hospitals were only open for a few months. We did keep one of them essentially in saran wrap, so to speak, so with some minimal staff and able to open it up immediately should we need it in the north. And then really in the summer, we started talking about the vaccine program. And as most people will remember, in the early parts of the vaccine, we didn't have much information. We heard that it could be anywhere from 1 to 6 vaccine products. At that point, the federal government had put a lot of money into a number of different products. Turned out that 3 were then received emergency use authorizations, but there were a few more that may be coming. We didn't, at that point, most of it we thought was going to require either cold chain or ultra cold chain. So not only did I get a nice, as an emergency physician, not only have I been getting a nice education in virology, but now also suddenly I was becoming, a vaccine specialist also. One of the great joys of working for the Department of Health is that you get to talk to literally the state experts on whatever subject you're talking about. So to be able to tap into the Vaccine Preventable Disease Program and people like Barbara Montana, who had spent years and decades dedicated to vaccines, had been incredibly important, but really trying to figure out how we were going to get this to the scale that we needed. And at the same time, be able to do all the testing that we were having at that point in the fall of 2021, larger scale, distribute a lot of the rapid antigen tests, particularly to long-term care facilities, hospitals, and a number of other places for use in it. Contact tracing was continuing, where it's much lower now, and we've scaled back sort of the expectations of disease investigation and contact tracing. At the beginning of the pandemic, the local health departments who were responsible for that subject probably could dedicate about 500-600 people to contact tracing. At its peak, the Department of Health, through some contracts, supplemented with almost 2,000 additional contact tracers in there. And we still maintain a fairly large number, but nowhere near that number right now, supporting the local health departments in their contact tracing efforts. From the emergency preparedness point of view, we didn't know if we were going to be what we were going to be seeing next, but a lot in terms of beds, the medications, ventilators. Remdesivir had become available, and that was initially distributed and allocated through the government. And then really this focus on the vaccines. From a point of view of the vaccines, we really started out in the very beginning saying we wanted 3 things. One, we wanted to try to get as equitable access as we could. We did okay on that. I think we did better as time went on. things that we did, things that we thought were going to make things more equitable. As an example, the ability for people, quite frankly, for let's say pharmacies to do online scheduling so that people could find a vaccine that was close to them, et cetera. That was great, but what we also realized is you can put a vaccine next to somebody who lives in the city of Newark in a chain pharmacy, but if they don't have time to get online for a couple hours a day in the very beginning and search for a vaccine dose, they weren't going to be the ones who were getting the doses, even though they were literally right next to them in where they lived in the pharmacy. So we did spend a lot of time trying to correct some of the initial assumptions we had and trying to figure out how to make, within the limits of some of the ordering caps and everything we had, how to make the vaccine as equitable as possible. I think we probably spent more time, and I know you all did, explain to people why they qualified for the vaccine, who a healthcare worker was, having people understand that not just nurses and doctors qualified as healthcare workers and the risk that they had if they were working in a hospital setting or in a healthcare setting, and why they'd be eligible for the vaccine. I think we've always talked about this idea of herd immunity, community protection. We didn't know what the effectiveness was going to look like. We didn't know about we didn't know that we were going to have to do boosters. We didn't necessarily know that there are going to be a number of variants, but I think minus the community protection part of certainly the effectiveness of these have done well. We also didn't know what the uptake was going to be. We had no idea if we were going to open up our vaccine clinics to crickets or to massive number of people wanting them. And then this one I think was incredibly important. We did not want to win the battle against COVID and lose the war with vaccines. That whatever we were going to do had to be professional, had to meet the standards that are the common standards for vaccination. We had to do it in a way that the public had trust in, so that we could not only build on the trust that people have in vaccines, but hopefully leave that legacy intact. And I think this one worked extraordinarily well. When we've had complaints related to our vaccine process, most of it was on the access side. Very, very infrequently do we have complaints around whether it's in physicians' offices, pharmacies, any of the mobile sites that we've had. We've had very few concerns related to the actual administration of the vaccine itself. And again, we had a vaccine task force that rapidly broke up into 10 or 12 different teams. We brought in the governor's office early, FEMA, essentially our partners and our operation partners, which is the Office of Emergency Management, which is run by the state police. We brought in local health departments. We brought in hospitals early. We tried to bring in as many people into the planning stage of this as possible. NJIAS, which I think a lot of you may be familiar with, particularly if you're administering vaccines to children, had a certain footprint, had a very specific way people could put information into it, and was not really at the level that we needed it to be able to handle this. We did not have a call center until, I think, January of 2021. That call center now has handled over 6 million incoming calls and has done something like and all of you have probably received a large percentage of them. I think they've done like 500 million text messages out reminding people. I get reminded all the time to get my booster, though I've had it. So I know it's not perfect, but we didn't have a call center. The way that the methods by which people reported in cases and positive test results needed to be updated. So a lot of this was bringing our logistical abilities and a lot of our technological abilities up, and then being able to get that information out to the providers and also get the information out to the various patients. My boss, I think during this time period, did somewhere around, I lose count, about 1,000 presentations to various stakeholder groups, whether they were elected officials, providers, physicians, stakeholder groups, religious leaders, et cetera. We really try to talk to as many people as we could throughout all the different stages of the vaccine process. And some of it was just, here's the information we have this week, and then next week when we came back to them, we would have more information. We're slightly different, trying to explain, the eligibility, et cetera, in those very early periods of time. So that brings us to where we are now, which I think is important to talk about the therapeutics. I think this is an area where while I think the federal response in terms of the vaccine, we've been able on a state level to amplify, I think, a lot of really well thought out, well developed information that encourage people on the vaccines and educated physicians, et cetera. The same thing I think we haven't necessarily seen that we've been able to amplify from the federal government when it comes to the therapeutics. And quite frankly, this is an area where just give a couple of weeks, whatever I'm talking about today will be a little bit different a couple of weeks from now in terms of what's available, what's currently being recommended, what effect that the variants have had, et cetera. So as of right now, this is at least about April 7th. On the prevention side, obviously vaccines remain our mainstay. And we do have essentially this monoclonal antibody that is a longer acting preventative called Evusheld. It is in about 55 different locations in New Jersey. Make this available. Most of the larger hospitals that have infusion centers, and quite frankly, we've also now been trying to get this into the specialty pharmacies that support long-term care facilities to make this available. I think we've moved from a point where supply has been a little less of an issue to trying to really educate people on the demand and really encouraging the providers that we are giving these medications to really reach out to their high-risk patients. So you're really thinking about the person who's got moderate or severe immunocompromise for a variety of reasons where the effectiveness of the vaccine is probably not large as candidates for the Evusheld. On the other side, obviously on the treatment, we remain having remdesivir, which is, while it can be now used on the outpatient basis, I think for a lot of reasons still remains generally in a parenteral treatment that has mainly been for inpatients. We now have the two oral antivirals, Paxlovid and molnupiravir. I know molnupiravir was recently renamed. Again, that's really happened in the last couple of weeks, so I'm just going to keep calling it molnupiravir. I think sometimes I've been invited to particularly be on the news, mainly because I can pronounce these words. I think they're just looking for, like, I swear there's at least one where they just cut to me, just basically I said the names of the medicines, and then they cut to somebody else to describe them. So I've gotten a long way being able to pronounce these. And again, as an emergency physician, to be able to talk about sotrovimab and bebtelovimab, et cetera, I'm kind of impressed with myself. And while we say monoclonal antibodies, right now it's monoclonal antibody. There's only really one of the monoclonals that is currently indicated as far as the federal government's concerned for the treatment of in the Omicron world, and that's bebtelovimab, and that's really a second-line agent. Sotrovimab, et cetera, Bemedi, all of those really, while they want us to maintain those stockpiles, there's really no indication for any of the monoclonals other than the bebtelovimab. So, again, I think the federal government had spent a lot of time talking about tying treatment to testing. I think that's great, but it forgets that there's a major component between those, which is the prescribing of it. These are medications that require a prescription, and quite frankly, require somewhat of an evaluation. And these are not, I think, not saying they're not benign, but they come with a host of questions that you need to ask, whether it's about the patient's renal status, if you're talking about Paxlovid, whether the patient's pregnant when you're talking about molnupiravir, some of the drug-drug interactions on the Paxlovid side that makes this a little bit difficult, and then trying to figure out the appropriateness of, should you start them on this, or should they be evaluated in a more of a hospital-based or an acute setting? Is remdesivir appropriate? So I'm all in favor, and we're working hard to try to cut down that time period from when people become symptomatic and become positive to receiving the medications, but we also recognize that there's a significant number of hurdles, not the least of which I think is educating prescribers and getting them comfortable with this. I was happy that last week that the CDC put out it was short, 2 pages, clarification / update on this, and I think the things that they really in that emphasized is, one, the importance of early treatment, particularly with, if it's appropriate, Paxlovid, and also I think specifically reiterating the fact that steroids do not have a role, particularly for those that are not hypoxic and do not have any other indications for it, even for those that are in the moderate to severe risk group, particularly for the outpatient. We're not talking about inpatient. And that also antibiotics, unless there's some other indication, do not necessarily have a role. So really it puts us at a point where we're really talking about Paxlovid, which is the one that, and again, the data on this is in the pre-Omicron era, so it's a little bit of wild type and a little more of Delta. But we haven't really seen any indications any different now in the Omicron world. We have one that appears to be highly effective, one that appears to be less effective, but the one that is highly effective comes with some significant concerns around its use in those who have any form of moderate or worse renal impairment. And the other one where the concern is whether or not it's a person who may be pregnant. So from a point of view of, we now have about 800 pharmacies in New Jersey that carry, well, take it back, we have 800 locations, majority of which are pharmacies that carry one or both of these. I think we have over 600 places that carry Paxlovid. I think we have, the federal government has a pretty good finder for it. But again, I think it's that the loop that has to be closed is the patient recognizing that they may be at risk if they come down with COVID, and that they should be tested early, and then to talk to their physician in order to find out if these medications. So it's not just, I think, educating the prescriber community. We also really need that help educating our at-risk patients that these may be potentially useful for them. Again, I won't get into a lot of this. We included this, and there's a link to Michigan Med has a pretty good walkthrough of sort of drug-drug interactions and some of the things that may make people a little bit more comfortable with the prescribing of it. I think this is one of the things where we have a pretty good idea of what the benefit of Paxlovid is. I think the risks related to drug-drug interactions, while they are real, I don't think we've provided as much information so you can balance and do as easy of a risk-benefit analysis. And then again, for molnupiravir, and for those that are either fans of Marvel or Norse mythology, molnupiravir is named after Thor's hammer, Mjolnir. When they told me that, I thought it was pretty impressive. I just thought that they probably, considering they named it after something that when you throw it at something, it never misses and always kills it, they probably should have had a stronger med, but I'm not making fun of it. This does have a role. I think a little less now that we have Paxlovid, but it does have a role. But yes, it is named after Mjolnir. So no therapeutic presentation is complete without some version of a decision tree. As you can see, there's some changes in this where sotrovimab had previously been. But essentially, I think what we come down to is in a patient who is at risk of a bad outcome. So think about the 50-year-old with hypertension, diabetes, the 75-year-old, my 93-year-old father who's at home. If appropriate, first-line agent we're talking about is Paxlovid with a renal adjustment. They've also come out with some better information on how to do the renal adjustments and also how to label these medications properly. We're obviously thinking about remdesivir. For those that this may not be appropriate for, then just to consider either bebtelovimab as an injectable monoclonal on molnupiravir, I think is essentially what this is. And again, I think the important part is we have these treatments. We know that they're being underused by the estimates of what the federal government has. And again, their reporting is not great. There's probably only been about 12 or 13,000 courses of Paxlovid given to patients in New Jersey so far. So it's not a large number. We know that there are other people who will benefit from this. And again, the locator actually really works pretty well to be able to find the medications. And while it's not 100% accurate, you know, generally we don't get a lot of complaints from people that they're trying to find it. And particularly for the chain pharmacies, pretty much you can find either Paxlovid at almost probably about 450 pharmacies right now. And, we're trying to increase that availability significantly. And so finally, just talk about sort of the preparing for the future. I think the first thing that we say is we don't know what the future is really going to need. I think this is has not been predictable. This is a novel virus. It has caused quite frankly, some novel problems for us that we're still working on. We really are focused on making sure that our surge capacity can come online quickly. Part of the problem, of course, you run into comes down to here, which is staff, vendors, and partners have a lot of fear about potential risks. If I'm going to build something, I want to know you're either going to use it or pay for it. We also know that while we do have about, from a Department of Health point of view, about $2.3 billion to spend, we spent probably about a little over $1 billion of that. That money all goes away roughly in summer of 2024. So all the people we've hired, all the additional staff that we've brought in to really give us the robust response that we currently have, we don't know what that looks like after 2024. We don't know what the federal government funding is going to look like. We've seen for some other things, particularly interestingly enough, with some of the funding that's come through for the investigation of case investigation, et cetera, and contact tracing for sexually transmitted infections. There was a 5-year grant that enabled us to almost double the number of people we were made available to counties and local health departments for that investigation. And that's over a 5-year period of time. So that gets us out to, I think I was getting us out to like 2026. So there have been some areas where we have a better idea of what it looks like, but for a lot, we really don't. I think we have to again focus on that. A lot of a lot of New Jerseyans are either medically or socially complex, and this one is a given. We've succeeded. Anything that we've succeeded is because the state has done what I think the state does well, which is to find money, find some larger resources, and coordinate. But the fact that the vast majority of whatever is going to happen, whether it's care or vaccines, was going to be done at the local level. And that requires this collaboration, which I think has been incredibly important. One of the things I'm proud about, this coming Monday, we will have our 207th vaccine coordinator update. We started 5 days a week on December 24th of 2020, so it was Christmas Eve, can't believe that. And then it went to 3 days a week and 1 day a week. We still have about 200 vaccine coordinators in the state of New Jersey who get on a call every week and participate in sort of a community and a question and answer. It's kind of like a weird talk radio show. We do a little bit of whatever the update is and we just answer their questions. But that level of collaboration to exist 16 months after we began this effort, I think really speaks to what we're going to need to be able to sustain if we're going to make this work. This is a big list of lessons learned. The bottom line is, I think, collaboration, cooperation, and communication remain the hallmarks of it. Those are things that are very easy to say. They are very difficult to do, and I think we have succeeded in ways that I don't want to see those alliances fall apart, because we have so many other things there we have to deal with, and now the Department of Health, I think, talks to so many individuals and so many groups on a regular basis. We need to find some ways to keep that. This one, I could spend kind of a lifetime talking about local health departments. They've been battered, as many people have in the last couple of years. They did not have a lot of resources to begin with. The amount of federal dollars that particularly we had to give to local health departments had diminished significantly over the last 10 years. And they are really the cornerstone of a lot of our response when it comes to public health. And then lastly, the importance of funding. Right now, the estimate is that all COVID funds, everything in New Jersey, is about $65 billion. For the Department of Health, I have to say it's a lot of money that we've spent, but we would not have had the vaccine programs we had, we would not have had the testing we had, we would not have had the contact tracing, the disease investigating reporting, the computer programs, the ventilators, the call center without a large influx of federal dollars. So all that stuff's really important, but I think part of it is the question that we're going to have going into the future is what do we need public health to be in New Jersey? Who does it need to work with more efficiently, more effectively? and where's the funding going to come from to be able to make sure that we're maintaining that ability even past COVID. And that's it. I'm happy if we have any time to take some questions. And just to show you how far we've come, that was the room everybody stored their PPE in at the field hospital, because at that point we were reusing everything. I think mine's on the left-hand side. The bags had your N95, and then obviously we also had the novel idea of we wrote everybody's name and what position you had, because everybody looks the same in a blue gown, and nobody knew each other in a field hospital, so it actually kind of also, in an odd way, really leveled the playing field in communication. Yes, sir.
Thank you, Doctor, for your update and for your service. A yeoman's task for sure. So the first question I have, and I have a couple, if my memory serves me correct, when the vaccines were first released the end of December a year ago, Moderna and Pfizer were about 95% effective and specific for the Wuhan strain. And then as time evolved and the Delta strain came, the vaccine efficacy was about 60 to 80%, if I'm correct.
Yeah,
roughly. And then with the advent of the South African variety, which is now Omicron, et cetera, the specificity dropped dramatically. So we're seeing a lot of cases in our practices where the patients who have been boosted are even getting the Omicron variant, mild disease. Now, would you anticipate that spike as a direct result of the lack of specificity for the antibodies generated by the first generation immunizations?
So without a doubt, in the very beginning, from my point of view, I was most excited that the efficacy was 95% or higher in keeping people out of hospitals or dying. Right. It also happened, the public got really excited that they were also about 95% effective in those first few weeks of preventing you from getting sick to begin with. We're at a situation right now where we're going to see these spikes in cases with smaller spikes in morbidity and mortality, so particularly hospitalization and death, because it's vaccinated people who are getting sick with it. I was exposed to COVID by my son, who got it at school, and had COVID within a month of getting my initial booster. So, I think part of what and we have to do a better job of, I think, talking to the public. It's confusing to me to keep track of who qualifies for what, and then you talk about the additional boosters, what do you do with people with J&J? But I agree with you. I think we have to really emphasize the part of the vaccines are not going to necessarily prevent you from getting COVID, or quite frankly, getting reinfected with COVID, because we are seeing reinfection. Right. I think we have to get back to the basics of they're designed to prevent the bad things from happening. I think you illustrate that pretty well.
Okay, and my next question is, next month, the governor has a mandate that all healthcare employees have to have a booster to maintain their current employability within a clinic setting. I was wondering if the governor was going to rescind that mandate anytime soon. And the reason why I say this, I have two employees, both working at the reception area of my office. They've had 2 shots and they got COVID last fall when it was likely Delta. Okay, they have antibody titers that are off the chart for active immunization, permanent immunity. And they're both refusing to get the shot. They're likely going to lose their job. So the question I have is, should they be losing their job, and why do they need to get the booster if they have antibodies that are off the chart?
So at this point, obviously you've pointed out pretty well what the executive order is on this. There was an extension made to that executive order, I think, to allow about 6 weeks of additional time. I have not heard anything from the governor's office that they intend to either rescind it or to provide another extension. There is built into the executive order, I don't think the executive order specifies that somebody who gets to that point has to be fired automatically. I think they put it on the employer to have a process by which they address it. But again, at this point, I haven't heard anything that if the governor has any intention to change or extend it at this point.
Yeah, I just have a quick question.
Sure.
They also were talking about these testing centers, if they got positive results, that they're going to have a process where they can treat them at that moment in time. I'm just curious what your thoughts are on that.
I'm in favor of anything that we can do cut, for particularly the high-risk people, to cut the time period down. The concerns that I will always have is that the most optimal thing, obviously, is to talk to your own physician, because that's the person who knows you the best, knows your medications the best. And I think the logistics of that has been very difficult to figure out. We do have a couple of places that are beginning to try to figure out how to incorporate their telehealth offerings, particularly some of the larger healthcare systems in the country, of how to use their telehealth to combine with people who find out they're positive, to do a telehealth visit rather than getting into the office. I still think we haven't found the right combination, though, of how do we do that, to be honest with you.
Just one other question is, even with these new products, at what level do you feel comfortable treating them? Because they really say to use it for high-risk patients, and then you always have these cases where, well, they have a couple high-risk situations, but the patients aren't really that ill. And at what point in time do you get aggressive with those patients?
Well, that's a good question. You know, so we approached, New Jersey really took the approach with the vaccines of saying, if you believe you fall into this category, then you qualify. So if you believe you're a healthcare provider in the very beginning, you should get the vaccine. And we spend most of our time telling people how they qualified for it. I think we're at a point right now with particularly the oral antivirals, where we have a lot of people who are qualified, who meet the criteria of being at moderate to severe risk. So again, that 50-year-old who's got hypertension, diabetes, and COPD, who is at risk but maybe just has mild symptoms right now, may not understand that they qualify for it. So I think we're less worried that you may give it to somebody who's less risk than we are just trying to increase the usage of it right now. That will change maybe in time, but I think we're really kind of emphasizing if you think the person's at risk of a hospitalization, you wouldn't be surprised if they were hospitalized for COVID, given their risk factors, that's the person you should be thinking about. Well, you can say it and then I'll rebound it, whatever you like. Got it. So if I understand, for those I think who couldn't hear, the question is, how time dependent is a transfer of antibodies from mother to child in the womb, both from a previous infection, or from specifically the vaccine? The answer, I don't think that they've gotten that granular. It's clear that, it seemed to be clear from the studies that those who had received the primary series versus just one dose seem to transfer more antibodies. We know the antibodies are only part of, well, obviously, what the immune system does. We know that their existence is somewhat time dependent and does decrease. So I don't think there's any great data around it. I will say that I think that part of the question that's come up, which is what's the role of natural immunity in this, is a question generically. I think the way we're approaching it is clearly people who've already had COVID are better protected than the people who have not had COVID against an infection. That immunity may not quite be as good, but for a time period may be as good as being vaccinated. But it is clear that those who have had an infection and also been vaccinated have much better protection than those who've just had quote unquote natural immunity. So I think that's what we're trying to emphasize, is particularly as we don't know what the next variant's going to be, whether it's from somebody who's pregnant or not pregnant, that even if you've had even if you've had COVID, the vaccine still, particularly for individuals who are at risk, still benefits them significantly. So I kind of answered your question. Then I took advantage of your question. I may have answered a lot of questions about COVID in the last couple of years. You never know. Right. So the question is, do the oral antivirals help with more than just preventing you from being hospitalized or dying? Does it help reduce the symptoms? I don't know if there's a good answer for it. I mean, I think people are also asking, can it help with long COVID, et cetera? I think that'll come out eventually, but really the studies were really geared to, look at specifically preventing hospitalization and death, really death more than anything else, and didn't look at things like transmissibility or length of symptoms. We would assume that they should make your symptoms, be shorter, but yeah, I don't think that's out there yet. Yes? Yeah, because the oral antivirals are still under an emergency use authorization, they probably have a larger requirement for sort of that post-marketing surveillance than you have otherwise. And I'm trying to think of what the equivalent is for VAERS for medications, but yes, the expectation is that there would be more studies, because there are some people who are reporting, side effects from the antivirals, and not atypical antiviral side effects like nausea and vomiting in particular. But I haven't seen a lot of that data come out, in at least anything I've seen so far. All right, well, I'm going to end this with enjoy your lunch. And again, I'm going to thank you all. You all have been out in the front lines dealing with this for the last 2 years. And from a Department of Health point of view, we really do appreciate you all every day. And we've tried not to mess with you too much. So thank you.